platform, giving you opportunity to apply all the features of our website. So this is briefly our the website presentation, and as for now, today our scope is the urology problems, which is explained by Dr. Wahid Zaman, who is one of the leading urologists in India, and I just want to check. Nimra, our doctor joined the. Oh,
I'm just waiting for you.
Good day. Good day, Dr. Nice to hear you, and thanks a lot for joining us and giving us.
Hello.
Hello. Please show us.
डॉक्टर त्रेहान फोर्थ फ्लोर ये जो अपना ऑफिस है ना इधर अच्छा से एकदम अंदर आ जाना कॉर्नर वाला रूम थोड़ा जल्दी
Dr. Zaman.
Namaskar, and can we start?
Yeah, sure, you can.
Sorry for being late here.
No problem, sir.
So today we are going to discuss about urology problems, current status. I am Dr. Wahid Zaman. I am Director, Department of Urology and Renal Transplant, Max Super Specialty Hospital, Shalimar Bagh, New Delhi, India. So today we will be discussing about various urological problems, but as you know, urology is a vast subject, and it is very difficult to cover within 40-45 minutes. So I will try to discuss few important topics. Before that, Omicron fear is all around in the world now. People are counting every day about Omicron numbers. So what is going to happen? Let's see in next few months. And we have to take we have to take all precautions to prevent Omicron variant spread. And so same presentation is almost same. Body ache, fatigue, sore throat, etc. But we have to take precautions to prevent this spread. So follow physical distancing, wear well-fitted masks, improve indoor ventilation, avoid crowded places, maintain hand hygiene, practice respiratory hygiene, and get vaccinated. That is the most important thing. And by this we can reduce its virulence and its spread. So I hope all of you are safe. I wish you all a safe and healthy future ahead, and let's come out of it, fight with it together. So urology is a vast subject, and we are going to discuss out of this. It is comprised of 8 subspecialties, if you see, right from endourology, andrology, laparoscopy urology, robotic urology, reconstructive urology, lab urology, and andrology. That is another important aspect. We deal erectile dysfunction and male infertility. Then trauma, genitourinary trauma, urinary tract infections, pediatric urology, that is very important. And last but not least, renal transplant. This is also part of the urology. So I am actually heading urology and renal transplant unit here in Max Shalimar Bagh. And it's a very well-equipped hospital, state of the art, and it is one of the best hospital in Max Group. So to start with, I'm very quickly, I will cover this. I think it is a mixed audience, doctors, nurses, and all learned persons are around. So I will try to be as non-technical as possible, but I will try to cover it, right? Very quickly. So please come with this pace of this presentation. So treatment of stone, it is very common in this subcontinent as well as I think in Middle East and other Far East, people are having this problem. Open surgery is almost obsolete. I have not done any open stone surgery in last 20 years in my active practice. What we do nowadays, it is all minimally invasive techniques like percutaneous nephrolithotomy, retrograde intrarenal surgery, RRS. There is no puncture at all in this. Even extracorporeal shock wave lithotripsy is going to be obsolete because nowadays people want stent result. In shock wave lithotripsy, it was not stent. This was the machine. Nowadays, it is almost obsolete, and very few centers are having this machine. At one point of time in early 2000, we used to do 6 to 8 lithotripsy per day for the select group of patients. It was very good treatment modality for select group of cases. With the shock wave, it is OPD procedure, less than 1 centimeter stone size, were very well managed, and especially for the upper ureteric and kidney stones. But with the time, people are more, with the pace, people want to run with the pace and they don't want to wait for 2-3 months for complete clearance. They want nowadays stent clearance on the same day, and very next day they want discharge. So we have to also work with that pace only, and with that harmony should be there because people want now instant treatment modality. So gradually it is now going to be obsolete in next few years. Another important armamentarium is Olvium laser in minimally invasive surgery for stone management. It's a very state of the art, very nice machine, luminous. They have got one of the best machine in the world now, and we can do prostate surgery as well as the stone surgery with this Olvium laser. So I will try to show you few of the. I'm very lucky that videos are running. So you can see this is a bladder stone, and we are managing with the Olvium laser and with this vesical calculi, and with the endoscopy. 6-7 stones were there in the bladder. It was due to bladder outlet obstruction. And with the different setting, power setting, with the Olvium laser, we can break these stones in few minutes. And we can make it, pulverize it, we can make powder, small fragments. And I think somebody has not muted. Some echo is there. So please unmute yourself or mute yourself, brother. Please mute yourself. Some echo is there in the background. So you can see in this case, the stone is fragmented and
yes, it's muted. You can continue.
is it visible?
Yes, it is.
Yeah, so stone is fragmented, and this is called CLT, cystolithotripsy with laser machine. Next is, you can see this ureteric stone. Nowadays, hardly we do open surgery for ureteric stone. 20-25 years back, it was uretolithotomy, but we hardly open anything, and within half an hour, we can fragment this stones. This is in the ureter. Ureter is the pipe connecting the kidney from the to the bladder. It is 25 centimeter long pipe, and the stone gets obstructed at various levels. There are 3 narrow points in the ureter. One is that it close to the kidney, second is close to the bladder, and third is at the vessel level, that is mid-ureter. So we can do uretroscopy. This is semi-rigid instrument, and with that you can see this blue. This is the laser probe. By this, through the uretroscope, we fragment this stone, and we can easily manage these ureteric stone cases with the laser and minimally invasive procedures. There are few more I will show you quickly, so that will give you clear picture. This is another stone. It's a hard stone definitely, but this case was previously had infection, so he was stented. So we just remove that stent and we are going to remove this stone directly. So within 15-20 minutes, this procedure is over. Next day, patient next day or same night, patient can be discharged. So it's a quite minimally invasive procedure, and with ureteroscope we can remove it very easily. It was in the lower ureter, and you can see this stone is coming out. There is another stone because ureteric stone is quite common. Almost you will see 60-70% of the stone burden is in the ureter because stones come down from the kidney and they get obstructed and gives severe ureteric colic to the patient. This is with the ureteroscope, semi-rigid ureteroscope, we are fragmenting this stone. And we'll remove all these fragments, and you can see small fragments as well as the pulverized part. They will be this powder will come out through the urine. We put this stent. Another popular procedure nowadays is RRS. RRS is retrograde intrarenal surgery. You can see this is flexible ureteroscope. It is quite costly instrument. We can go reach from the urethra to the bladder, and we can reach up to directly to the kidney through ureter. So it's a long ureteroscope, flexible ureteroscope. You can see in this picture, it depicts very clearly that we enter through the urethra, then to the bladder, and through the ureter we can remove a stone from the ureter as well as from the kidney. And we take the help of this laser machine, state-of-the-art laser machine. So RRS is very popular nowadays, and large number of cases we are managing with the RRS, and people don't want even puncture nowadays. They will say we want RRS or without puncture stone should be removed. So up to 2 centimeter kidney stones we are removing with RRS, and very next day patient can be discharged. The prerequisite culture should be negative, and this ureter should be wide enough to we can pass this flexible ureteroscope. It should be wide enough. That is the main reason, and that is the main success. If we can do it, we can reach easily up to all parts of the kidney, and we can pick up all stones. So this is another case. You can see this is a staghorn stone in the pelvis and multiple kidney stones. And we did PCNL, that is another method, percutaneous nephrolithotomy, by simple puncture, 1 to 2 centimeter puncture in the back, and we directly puncture the kidney and dilate that tract, and we remove these stone fragments. We fragment with either lithoclast or with the laser, and we can remove all these stones. You can see within 1.5 hours, we removed all this stone, and it is absolutely clear in very first setting. So this is for big stone, more than 2 centimeter stones, multiple stones, staghorn stones. PCNL is the treatment of choice all over the world. But for less than 2 centimeter solitary stone, usually we go for RIRS. That is retrograde intrarenal surgery. So another important topic. So stone management is very important, and prevention is also very important. So we have to prevent the disease. It is prevalent all over the, I told, in our part of the world, in the Asia, the subcontinent, it is full of stone disease. So we have to prevent this disease, drink plenty of water, improve your food habits, reduce red meat intake, and take plenty of water because it is a hot climate, tropical climate. Now the next important thing is prostate, management of enlarged prostate. With this you can see normally we pass the urine through from bladder to the urethra through the prostate. This is the gland. This is walnut-shaped gland, spherical gland at just below the bladder. And when it gets enlarged, it narrows this passage. And that is called enlargement of prostate and bladder outlet obstruction. So it may be benign prostatic enlargement, prostate aerodynamically proven bladder outlet obstruction may be there. I have to go very quickly through this. So this is the structure, walnut-shaped structure just below the uh, uh, urinary bladder, and this is the prostate, and it encircles the proximal part of the urethra, that is prostatic urethra, and this is the urethral passage, male urethral passage. So it is a accessory male reproductive organ. It surrounds the urethra and it provides some secretions to the seminal fluid. So half of all men over the age of 60 will develop an enlarged prostate. Prostate starts increasing in size from the age of 30 and 40, and by the age of 60, almost 50% will have enlarged prostate, and by the age of 80 or 90, this enlargement is almost 80 to 90% people are symptomatic. This is the detail. I will not go. Main is the transition zone where this adenoma develops and cancer develops in the peripheral zone. This is very important. Another thing we have to understand, if you remove the transition zone, that is with the benign enlargement of prostate, still chances of cancer remains because this is the peripheral zone, we are not removing it. And this is the urethra. So urethra passes through the prostate. So BPH is part of the natural aging process like getting grey hair or wearing glasses. So BPH cannot be prevented. BPH can be treated. So what are the symptoms? Lower urinary symptoms. It may be hesitancy, weak stream, straining, or there may be storage symptoms like urgency, frequency, night frequency, and urgent incontinence. So various symptoms, hesitancy, intermittency, these are obstructive symptoms, and irritative is frequency and nocturia and urgency and urgent incontinence. The goals of therapy for benign prostatic enlargement, this is very common, and almost 70-80% people will suffer from this disease. The significant disease is seen only in 20 to 30% of population, male population. So symptoms are very important. IPSS is international symptom score, AUA score system is there, and how much it is bothering the patient, that is important. Enlargement of prostate is not important. How much it is bothering the patient, that is important. So there may be increase or decrease in the peak flow rate that we usually assess. So symptoms are severe enough to bother the patient and affects the quality of life, how much it is affecting, and the complications related to BPH. This is the part when we have to treat BPH. So what happens with BPH? Benign prostatic hyperplasia, benign enlargement of prostate that leads to urinary tract symptoms, urinary tract infection, acute urinary retention, urine gets obstructed and fails to pass urine, bladder calculi, bladder gets damaged, it is thickened and trabeculated bladder, and at the later stage, there may be even renal impairment. The kidney function will go down, and sometimes blood in urine. So in other way, these are the absolute indications for the managing BPH cases, enlarged prostate cases, when there is recurrent retention, recurrent urinary tract infection, recurrent hematuria, retention of urine, and renal impairment, or there is bladder diverticula or stone. In all those cases, we have to manage enlarged prostate cases, and medical management is not advisable in these cases. We have to operate. So this is very important. This is the common algorithm. If there is mild symptoms, we can even wait and watch. We can add some medicines. I'm not going to the details of this. If it is moderate symptoms, then again there are two important drugs, 5-alpha reductase inhibitors, and most important is alpha-adrenergic blockers. The 5-alpha reductase inhibitors can reduce even prostate size. If you take it for 1 year, it reduces the prostate size by 20%. While alpha blockers, it works for 24 to 36 hours and it improves the flow. But with the medical management, we can keep cure to 30% of people. 30% people will remain as such, and 30% will deteriorate. One third. So 1/3 of people on medical management ultimately lands up with the surgical management. This is the thing mainly. So surgery is usually advisable when there is, I have already told, recurrent UTI, recurrent bleeding, blood in urine, or there is any stone or diverticula in the bladder, or kidney damage or retention. In that cases, these are the absolute indication for treatment in BPH. So watchful waiting, medication and surgical options. Hence, if you see the lifestyle changes, these are also very important. Reduce the stress, do regular exercise, take fresh fish, fruits, vegetables regularly, take plenty of water, decrease bladder irritant, coffee, alcohol, etc. And smoking, reduce the smoking as well, and limit your weight also. These are the lifestyle changes. By this, few symptoms can be reduced significantly. So I have already told medical management and surgical management. Medical management, we can manage a large number of cases with this and symptomatic relief can be achieved. And with alpha blocker even, you can see this cartoon showing that the flow has improved so much. So surgical treatments of BPH, these are right from the historical, that is suprapubic or retropubic prostatectomy. I haven't really done open prostate surgery for last 20-25 years. We are all doing the endoscopic surgery, that is transurethral prostatectomy, TURP. That is the most important, and it is present all over the world, and it is still the gold standard. But there are few limitations. Chances of bleeding is high. We cannot do in the large prostate, and chances of various complications are there, like TURP syndrome. So, of course, obstructive symptoms can be reduced by 80 to 90% with this, but almost 30% of irritative symptoms are improved with TURP. With in this pictorial presentation, you can see these are resected. Both lobes are resected and passage is wide open. So there is low mortality rate of 0.2%, and but around 30% of tissue remains behind. So gold standard is TURP, still for the management of prostate enlargement, but it is widely available all over the world. But the risk of complication is more stay, and catheter is to be kept for 3 to 5 days, and recovery time is 4 to 6 weeks. Latest one is long laser prostatectomy, and in Max we provide the holmium laser prostatectomy. I think we are doing large number of holmium laser prostatectomy, highest in India, that is HOLAP. And holmium laser enucleation of prostate is done in our center with excellent result. We have removed up to 250-300 gram prostate with this holmium laser. So it is excellent mode of treatment. The others are various like transurethral laser ablation and this, but still it has it has maintained itself, and still I think after TRP, HOLAP is the most popular one. But of course, it needs good training and experience to deal with this technique. So there is enucleation of the prostate is done, and then we morcellate the prostate tissue from the bladder, and almost 90% of the tissue can be removed with this holmium laser. So these are the main advantages of HOLAP. Large size prostate can be done, minimal bleeding, discharge within 1 to 2 days. Recurrence chances are very low because almost 90% of tissue is removed, less charring of the tissue, less post-operative UTI, and PSA also drops down significantly after this surgery. It's very useful for large prostate, for cardiac comorbid conditions, patients who are cardiac patients, on patients on blood thinner. No need to stop blood thinners in HOLAP. You can see pre-op, it is obstructing, bladder is not seen. Immediate post-op, this is the scenario. We enucleate the prostate, and after 3 months, you can see this is wide bladder neck, and patient voids very well. So, when we should treat BPH, when there is severe symptoms, as I told, medical management, alpha-adrenergic blockers are the most important. It improves the flow. If you want to reduce the size, then 5-alpha reductase inhibitors. When patient is having irritative symptoms, we add the anticholinergics. So I'm not going into the details of this further. And now, uro-onco section we are having large number of uro-onco cases we are dealing in our center. And the most important of this is renal tumors. In this CT, you can see it's a large exophytic mass, and large exophytic mass is seen, and that is removed laparoscopically. That is lab radical nephrectomy has been done in this case. This is another tumor. It's a very big tumor. You can say 20 by 15 centimeter size with IVC thrombus. Due to this IVC thrombus, we managed. This is done 5 years back, and we managed it with open surgery. And we removed the kidney along with the IVC thrombectomy we have done. You can see it's a very big tumor. So various risk factors for kidney tumors are tobacco chewing, smokers, obesity, hypertension, lead compounds or aromatic hydrocarbons, congestions, and in patients of end-stage renal disease. This is quite common. Developing RCC, this is the commonest type of renal tumor, and it is almost 2% of all in male populations. It is seen worldwide. It is one of the commonest tumor and 7th commonest cancer worldwide. That is called RCC, renal cell carcinoma. And we manage here with various techniques. One is the radical nephrectomy when tumor is very big. Partial nephrectomy, in this case, like we excise the tumor and then repair it. That is partial nephrectomy or nephron sparing surgery. This is especially at one point of time it was indicated when there is bilateral tumor or in the solitary tumor, the solitary kidney there is tumor. In that case, we have to save the kidney. So now it is even normal contralateral side and there is tumor of even less than 7 centimeter size. We try to preserve the kidney. This is another tumor. You can see the upper pole tumor. Recently we have removed, and partial nephrectomy was done laparoscopically. And this is another tumor. This is very interesting case we have done. Sunita madam will tell this story. Definitely, this is the case we have done from Bangladesh, presented to us with the kidney stone on one side and renal tumor. You can see this is 5 by 4 centimeter kidney tumor on the right side, and simultaneously in the same sitting we have operated both. First we did the PCNL and everything was fine. There was no bleeding after doing PCNL, that is percutaneous nephrolithotomy, removal of stone from the kidney by percutaneous technique, and then we removed this kidney laparoscopically, that is partial nephrectomy was done, and patient is almost 6 months post-op doing well. This was the tumor. So the technique of partial nephrectomy, we remove the tumor and then we achieve the hemostasis by various techniques. We are doing with the suturing technique, and after laparoscopy, robot has really changed the scenario. We have got the Da Vinci Xi model now in our hospital, and we are managing now partial nephrectomy cases, radical prostatectomy, radical cystectomy. These all cases robotically with robot-assisted laparoscopic technique. So with this, we are managing these very difficult cases in our center. So another important cancer is bladder cancer. It is quite common in this part of the world. In our cases, it is TCC is more common, but in Middle East, it is the squamous cell carcinoma is more common, cystobioma infection. So that may lead to squamous cell carcinoma. It's a very important cancer. Second commonest urological malignancy and the 8th commonest cancer in men. Male female ratio 4:1, more common in male, and age group usually 60 and 70s. So various risk factors: smoking, exposure to the nitrosamine, aromatic hydrocarbons, dye industry, chronic UTI, long-term dwelling, indwelling catheter, bladder stone, BPH with chronic retention. As I told you, cystoma, hematobium, they all lead to this cancer, bladder cancer. And it is diagnosed first by the ultrasound, followed by CT scan, and if required by MRI. This is, you can see in CT urography, This is the bladder mass. So it is very sensitive, and if required, then we can do MRI also. You can see this the small bladder masses. It was not detected initially with the CT, and it even detects the muscle invasion. Cystoscopy is the gold standard. By doing cystoscopy, we localize the tumor, and in the same setting, we resect the tumor, we take the deep biopsy, and based on that biopsy, further treatment is done. In this video, you can see we started this surgery for the right ureteric stone removal. But on cystoscopy, what we saw, this tumor, small incidentally detected tumor. Can you see this? So this was incidental finding around 5 by 8 millimeter size bladder tumor. Rest of the bladder was normal. So it was incidentally detected tumor and it was superficial. At this stage, we can control the disease and it is curable. Can you see this tumor? Next is this. In this video, you can see this is papilliferous tumor and almost left lateral wall, multiple tumors, left lateral wall, big mass. This is the bladder mass. And we resected this whole tumor endoscopically. That is called transurethral resection of bladder tumor with deep biopsy. And based on biopsy report, we decide about the treatment modality. So there are various other techniques. We try to convert with the replace the cystoscopy, but still cystoscopy is the gold standard. If we detect it, it has to be repeated every 3 monthly. And management is based on the this tumor depth of this tumor, whether it is superficial or deep. It is non-muscle invasive and invasive bladder tumor, muscle invasive, and based on this, tumor is decided. 80% of the bladder tumors are non-muscle invasive bladder cancer, while 20% are diagnosed as muscle invasive bladder. Where bladder wall is involved. In that case, total treatment modality will be different. Then the risk stratification, low risk tumors, intermediate and high risk tumors, how it has to be managed, and that is based on this risk factors and the depth of the tumor. So, for the non-muscle invasive bladder tumor, the treatment of choice is TURBT with a single dose of mitomycin for low risk disease. For intermediate and high risk, it is TURBT and BCG installation after 3 to 4 weeks in form of induction therapy and the maintenance therapy for 1 year. So, for intermediate and high risk tumors, non-muscle invasive bladder tumor, we can save the bladder and BCG, intravesical BCG therapy is required. For muscle invasive bladder cancer, radical cystectomy, that is neoadjuvant radical cystectomy with the chemotherapy, chemoradiotherapy is advisable, and nowadays many immunotherapy and adjuvant chemotherapy are available. So for muscle invasive, definitely treatment is difficult, but still cure can be achieved with this. With metastatic disease, definitely metastatic CA bladder, then various chemotherapeutic and immunotherapy agents are to be given. So we have got good, in uro-onco, we deal with our urologists are dealing the uro-oncology, and whenever required, we take the help of our radiation oncologist and medical oncologist for further chemotherapy and immunotherapy. So this is the collaborative treatment facility available in our hospital. Another important cancer, prostatic cancer, is prostate carcinoma. You must have heard, it's a very important. Prostate cancer is the most common non-cutaneous cancer and the second leading cause of the death all over the world. Prevalence of prostate cancer is increased slightly with age nowadays, and is, as you know, enlargement of prostate is the disease of aging. So, by the age of 9 decade, almost 3/4 people are suffering from this disease, microscopic or macroscopic. So, age is most important. Then family history is also another important factor. If family history is there, then The one important investigation is there in this case I would like to mention, that is serum PSA level. That is prostate specific antigen. This is a blood test. Serum PSA has to be done. Those who are suffering with the lower urinary tract symptoms, the male population after the age of 50, they should undergo this test. It's a simple blood test. Same day you get the result once in a year after 50. But if there is any family history of the prostate cancer, then this screening should be started from the 40 years and above. With the early detection of the prostate cancer, complete cure can be achieved. The various symptoms of the prostate, CA prostate, are dull pain in the lower pelvis, lower intake symptoms, hematuria, painful ejaculation, bony pain, and lower limb weakness. And on DRE, that is digital rectal examination, we found the hard nodule, painless, median circle. I'm not going into the details of this. So diagnosis based mainly on the total PSA level, and based on that and various other raised PSA, age-specific PSA, and various imaging modalities like transrectal ultrasound, multiparametric MRI, CT abdomen, and PSMA PET scan will give the further details. So if there is high risk prostate cancer, local staging is there, means it is confined to the seminal vesicle, distant when there is pelvis and lymph nodes and visceral metastases are involved. In that case, we need PSMA PET scan. For the bone staging, that is the bone scan has to be done. But nowadays with the PET CT, we can achieve both CT and bone scan. So clinical stage of progression, if you see, is clinically localized disease, and biochemical relapse can be seen, non-metastatic hormone and metastatic hormonal disease. I'm not going into the details. Treatments are available, and 10-year survival with good treatment is almost 70 to 80%. Another is when there is locally advanced disease, we go for radical prostatectomy or radiotherapy or watchful waiting if life expectancy is less than 5. And few chemotherapeutic agents are available like docetaxel that can be given upfront in the advanced disease. So another important is laparoscopy in urology, that is lab simple radical or partial nephrectomy is done, or lab donor nephrectomy, lab pyeloplasty, cyst deroofing is done, uretic reimplantation, radical diverticulectomy, and lab radical prostatectomy. Lab radical prostatectomy has really changed the scenario and management of the prostate cancer. This is one simple example. One small little boy presented with obstruction at the kidney, that is UPJ obstruction. It is very commonest congenital abnormality of the kidney. And we managed with the, this is 6-7 years back, we managed with the open surgery. That is lab pyeloplasty was done. It's a small procedure, but by open surgery, repair that part and we rejoin the ureter with the bladder. That is pyeloplasty. But nowadays we are doing with the laparoscopy, that is laparoscopic Anderson Hayek's pyeloplasty, and we can mobilize and this we can obstruction, we cut open, we excise the adynamic segment and do the uretropelvic anastomosis. Another important use of laparoscopy we are doing, that is lab donor nephrectomy. Our center is the only center doing 100% laparoscopic donor nephrectomy, even for the right-sided or any type of complicated kidney. Donor kidney, we are doing laparoscopically. So as I told you, recently we got our robotic machine in Max Shalimar Bagh, and this is really, this is the latest machine we have, that is Da Vinci XI model, and this is really, it has going to change the scenario of the management of the reconstructive surgery as well as the uro-onco and other onco surgery cases. So it is minimally invasive and precise technique, minimal blood loss, and there is faster recovery. Within 2 to 3 days, patient can recover with this. So we have introduced it and started operating with excellent results. So I will discuss the another important topic in urology, that is urethral stricture disease. Urethral stricture disease means the narrowing of the urethra. This is RGMC. You can see there is complete distraction, and or multiple narrow beading-like appearance in this stage also. These are all narrow points, and this is the stricture urethra. It is narrowing of the urethra. This is following fracture pelvis. There is complete disruption of the prostatic urethra. So there is complete disruption, and this is after surgery. You can see we have managed this with the anastomosis and with the posterior urethra, with the bulbar, end-to-end anastomosis, and this is the result. So various end-to-end anastomotic urethroplasty cases. Very quickly, I'll go through few X-rays. You can see small segment bulbar urethral stricture, and we manage with the urethroplasty. Another important is buccal mucosal graft urethroplasty. It is very popular, and large number of cases are coming from Africa, Middle East. We are getting this patient with for the long stricture urethra, and we are managing this defect with the buccal mucosa. We harvest the buccal mucosa from the both the chins we can take, and we put it into the urethra and widen the urethra with this. That is buccal mucosal graft urethroplasty. This is another type of structure around 3 centimeter long, bulbar urethral structure, and we manage with the mobilization of urethra and end-to-end anastomosis was done. This is another case with dorsal only graft, and this is the closure and complete. The passage was normal. When we passed the catheter, absolutely it went easily, and we removed the catheter after 3 weeks, and patient is doing very well. This is another long anterior urethral stricture up to bulbar urethra. It is okay, and then it is narrow. So in this case, we have to lay open stage urethroplasty. We lay open the urethra, made perineal uretrostomy, and after few months, you can see this is perineal uretrostomy, and after few months, we managed it with second stage urethroplasty. So this is very important aspect of our hospital, that is KTP unit, kidney transplant unit, and we have got state-of-the-art kidney transplant unit here. Hundreds of cases have been managed in last 6-7 years, and I'm adding the department, and we are doing mainly the live-related kidney transplant. Of course, we have done cadaveric kidney transplant also, but percentage is very less, around 5% only. We have done the cadaveric transplant. So majority we have done the left donor nephrectomy and the right donor nephrectomies, and all are laparoscopic donor nephrectomy. Staging of the CKD, if you see, it is in 5 stages. Stage 1, when it is DMFR is more than 90. Stage 2, when 60 to 89. Stage 3, when it is 30 to 59. Stage 4, when it is 15 to 29. And stage 5, when it is less than 15. When it is less than 15, it further progresses into end-stage renal disease. So global burden of CKD, if you say CKD is becoming a global epidemic, and the cost of treatment of ESRD is very prohibitive. It is end-stage renal disease. Even the developed countries are feeling the pinch, and the patients in developing countries just cannot afford. Even developed countries are facing the pinch. So, etiology, most common chronic kidney disease, the primary kidney disease, or it may be systemic disease. The most common cause of end-stage renal disease in our part of the world is diabetes and hypertension, and the same story, I think it is all over the world. Almost 60% of the CKD is due to diabetes and hypertension, followed by chronic glomerulonephritis. When there is renal failure, this is end-stage renal disease. There are 2 options only: dialysis and renal transplant. This is called renal replacement therapy, and to manage and to live further, we need dialysis or renal transplant. But with dialysis, we cannot have the quality of life, and we cannot do normal work. Quality of life is very poor. With renal transplant, we can achieve around, in an average, around 12 to 15 years extra life for with the kidney, that is the graft kidney, and quality of life is far better than patients on hemodialysis. So options of renal replacement are hemodialysis, and this is the kidney transplant. We usually put in the right iliac fossa, you can see in the recipient, and this is the donor kidney. We have grafted into the this lower lower abdominal vessels. And this is the transplanted kidney. So, need of the hour, Indian figures, 10 lakhs people need organ donation per year, but hardly we are doing in India 10 to 11,000 kidney transplant. And is far less, requirement is more than 1.5. So we are lagging behind. We need actually robust cadaveric transplant program. We are lagging behind. We are working on this to further popularize this. So living related transplant donor may be living unrelated, emotionally motivated donors or the cadaveric donors. These are the types of donors, that is brain dead people, beating and non-heart beating heart. So transplantation may be with live or with the cadaveric donors, and this is the difference between open and laparoscopic nephrectomy. You can see there is such a big scar on the with the open surgery when we used to do donor nephrectomy almost 15-18 years back. But now we are managing with 3 to 4 foot technique, and with the fenestrial, that is Pinckney incision, we are removing the kidney. There is minimal scar. You can see this is another view, and this is the open donor nephrectomy, and this is laparoscopic donor nephrectomy. In the first week, few scars are seen, and gradually it becomes absolutely normal. And minimal scar will be seen and can maintain the physical appearance. You can see post-op image. Hardly you can see after a few weeks any scar. So another important, I would like to discuss here, we are doing kidney transplant here, all live related and few cadaveric transplant. This is one of the transplant procedure I like. We got the video of one of the case. It's very difficult to make video during transplant on YouTube. We will try, very few videos are available because it is very tense moment.
Hi.
Thanks so much for your presentation. We really appreciate it. Now we ask our participants, sorry, if you have any questions, you can ask our doctor and he will answer you everything.
Anyone can ask a question with the doctor.
Hello.
Yes, everyone can ask any question regarding the presentation or the topics which are near to it. So if anyone wants to ask anything, if anyone has questions, please, we are open to answer them. Or besides the presentation, you can ask us about the Medhop Second Opinion platform and any further collaboration opportunities.
If anyone is suffering from that type of disease, he can ask the question with the doctor.
Okay, and also you can just write your message to our chat, and we will see, and our doctor will answer it.
I have one question. Maybe I can ask. Maybe I can ask the doctor. I have a question about the kidney transplant. Kidney transplant is very difficult issues nowadays, and they have some complications. After transplant the kidney, they have some lots of complications. So, our sir, Mr. So,
Actually, is asking a question regarding kidney problems. Regarding kidney transplant.
when any kidney patient need to transplant his or her kidney, so how they survive after transplant? What's the procedure? They can survive, or they have no chance to survive after transplant. So I need to know if you have more details about that.
Dr. Wahid, transplant success rate is 99%. 99% patients survive.
How long it takes after transplant? I mean, 3 years, 4 years, maybe 10 years after transplant. And should they need dialysis after kidney transplant?
No need of any dialysis after the transplant.
Oh, okay.
After transplant, successful transplant,
Yes, sir.
there is no need for any dialysis. You can get complete normal and can lead normal life, can be discharged our patients easily by the 6th or 7th post-operative day. No dialysis required until unfortunately some ATN has
Actually, I didn't get the voices because the voice is interrupted. Lots more interruption here.
transplant, it might need 1 or 2 sessions of dialysis. Otherwise, no dialysis is required. No.
If there any patient have their age limit is 60, above 60. Okay, if the patient their age is above 60, is there any possibilities to transplant these 60 above people, male or female? Sir?
Yeah, we have done transplant even in 60. We have done transplant even in 70, 67, 68 years old recipient also. If they are fit, no comorbid condition, we can do transplant.
Okay, this is very
So
important.
age is not the limit.
Oh, I see. So, if any patient need to plan to transplant their kidneys, so what is the procedure? When he starts for planning to transplant his kidney, what's the, how long it takes, total procedure?
First basic thing is we should have a proper report of KFT. Serum creatinine must be high, CKD 5, right? CKD 5 when it is labeled by nephrologists as ESRD, end stage renal disease. Then second is we have to see the blood group. What is the blood group? AB and O blood group. And based on this, we have to see the donor. And best results are achieved with the family donors. This is the bottom line. If you do with the family donors, these kidneys are bound to work for 15-20 years. On an average, it is said that 12 to 15 years of age in the life donor, 2000, and still they are working. So the large number of patients now. So the bottom line, if it is family donor, it is going to work because actually a match will be better and long-term results are pretty high.
Okay, I'm Understand.
But with the emotionally related, like wife, still we are doing transplant. It is legally allowed, but the emotionally related donor. So in that case, it works, but we need some special medicines for this. Now, next point is blood group matching. If A is the recipient blood group, we can get kidney from A and O. Similarly, B can get from B and O donors. AB can get from any donor, A, B, AB and O. But in case of O blood group recipient, they can get kidney only from O.
Understand.
But nowadays, scenario has changed, and we are doing ABO incompatible transplant. If ABO incompatible transplant in our centers, we have done large number of centers, a large number of cases. It is well established Japanese technique, and after Japan, US has adopted, and the early 2010, we have adopted this technique of ABO incompatible transplant. That has increased the donor pool. That is, even without blood group match, we can have transplant. Like A can get from B, O can get AB. So that bonding is overcome by.
Okay, I understand, sir. So anybody can take from any person. Anybody can take from any person kidney. Family is preferred.
Of ABO incompatible transplants. Of course, this is slightly costlier. It will cost you blood group. That is ABO or exchange program also. When suppose one group is having A and B blood group, B is the donor. In one pair, the opposite pair is having B and A blood group, A is the donor. So that second pair will give kidney to this first pair, and the first pair donor will give to second pair. This is called donor exchange kidney transplant, and that is swapping, and that is at this point of time it is only available for Indian population. Only very few centers have done with the international patient because it takes time for this matching. So for international patient, it is ABO incompatible transplant, and of course ABO compatible transplant. ABO compatible is the first choice. If blood group matching is not there, then by simple antibody titer, we can see the matching, and we can do plasmapheresis. Special filters can be used, and we can have ABO incompatible transplant also. So that is very useful. Almost equal results can be achieved with this.
Oh, very good, very good. Oh, very good to hear, sir. So, for kidney transplant, any patient from international, how long it takes total procedure? How long? 1 month or 20 days or 15 days?
4 to 6 weeks. 4 to 6 weeks.
1.5 months.
If they come with all 1.5, because they have to go to external committee. If paperwork is good, it can be over in 3 to 4 weeks. If paperwork is good.
I understand.
And family donor. Family donor is very important, because then legally you can show any papers, right?
Yeah, sure. Sure, sir.
Right from passport and other national cards.
Yeah.
So many things are there. Everything will match very quickly. We can contact the committee for transplant. We need approval from the government.
I understand that. So, for this operation, this transplant operation, how much it takes? I mean, money, how much need for every single patient for one transplant?
Money wise, it is overall around $12,000 to $15,000.
$12,000 to $15,000.
Transplant package. Complete package, including immunosuppressant, stay, everything, $15,000.
$15,000. Okay, I understand.
Actually, cost varies patient to patient. Patient country.
Patient to patient, it varies. What are other requirements? What other testings are required? So it varies from 12,000 to 15,000 in that range.
How much dialysis patient need? Everything matter in that condition.
Because in package you get the limited dialysis. If you need more dialysis, that will be additional. Your stay, your food, everything will be additional.
Yeah, I understand, sir. Sir,
If you need any special investigations, if you go for ABO incompatible transplant, definitely it will add another $6,000 to $8,000 for ABO incompatible.
if compatible, then 12 to 15,000 enough. If incompatible, then another $6,000 to $8,000 needed for this matching. Sir.
Some DNA tests and in
Yeah, depending on the titer level, because we are, so that depends on how much matching is there. Based on that, the cost will vary. Definitely.
I have one patient. She is a female patient. Her age 70 plus. Her two kidney damaged already, 95% plus damaged, and she taken per weekly dialysis. By using this dialysis, she is surviving now, but she didn't think about the transplant because of her age. She has another problem also.
No, what's
70 plus, sir. 70 plus.
70 plus is slightly.
What do you think, sir? Is there any possibility to change her kidney?
If there is no cardiac or drowning on the dialysis, will be better option.
Yeah. 3 times a week she taken dialysis. 3 times a week. The 95% plus damaged both kidneys, sir. Yeah. So no hope, sir.
Or yes, she can be shipped.
there is a hope.
This is
You can't say like that there is no hope, because after seeing the report, Dr. Wahid can tell you what exact treatment will be go.
There is hope. Even we can, there is no need for hemodialysis. We can convert these cases to CAPD. That is continuous ambulatory peritoneal dialysis. This dialysis can be done at home if peritoneal fluid is available in your country. This is called peritoneal dialysis. Painless dialysis can be managed at home, 3 times cycles. Just we have to put fluid in the peritoneal cavity. We implant that catheter inside peritoneal cavity, and this is exchanged every day, 2 to 3 times. Can be managed at home with excellent result. Better than hemodialysis if you can manage.
Okay, I understand.
That is CAPD, continuous ambulatory peritoneal dialysis. That is superior than hemodialysis.
Understand, sir.
For elderly people, it is very good. No blood, no BP fluctuation, nothing.
How much cost needs, sir, for this CAPD?
CAPD is even cheaper than hemodialysis.
Yeah.
Monthly cost.
Monthly cost.
Catheter insertion will cost you around 1,500 to 2,000 USD. And then you can manage, if in your country there is peritoneal dialysis fluid is available, then it can be easily managed. The various companies are available like Baxter. I think it is available in Bangladesh also. You are from Bangladesh, sir?
Yes, sir. I am from Bangladesh, sir. Yes, sir.
Yeah, I think Baxter is available in Bangladesh. You can find out. And CAPD is very good option. There will be no BP fluctuation. The only risk of infection is there, that can be managed, because nowadays special bags are available, and that reduces the infection significantly.
Okay, sir.
No blood loss, nothing. It can be managed at home. CAPD, very important.
So every month you pay $2,000 for this treatment, sir.
No, for insertion of this catheter, special
Oh.
catheter.
Oh.
And then treatment will depend on the number of cycles to be done per day. And next is whether that is available in your country, Baxter.
Yeah.
I think it is available in your country.
Okay.
And they have got trainers, they will train at your home
Yeah.
and very easily managed.
No, okay. Understood, sir. Okay, thank you, sir, for this answer.
Any specific question, anything? On we are dealing large number of kidney tumors, bladder tumors, and prostate cancer cases in our center, and we have got now robotic machine, that is Da Vinci XI machine. With this, we can do large number of these cases. I have done one case I have shown in between my presentation. With one side kidney stone and another side kidney tumor, we managed in the same setting. Within 3.5 hours, we removed the stone from the left kidney, and then we did partial nephrectomy and removed the tumor. Patient is doing very well. It's from your country only. So we have large number of patients of tumors, and nowadays we are managing it with partial nephrectomy. We are getting many queries. Now number of radical nephrectomy, complete removal of kidney has gone down significantly, and majority can be managed by removal of the tumor only. So this technique is very popular now worldwide, and with the facility of robot surgery, robot assisted partial nephrectomy can be done easily with minimal morbidity.
Hi, Dr.
Any question from
Yes, Dr. Wahid. Thank you for your
Assalamu
wonderful
alaikum.
presentation. Walaikum assalam warahmatullah. This is from Aman.
Okay.
Doctor, my question is regarding this uncontrolled bladder, because we have seen different patients with paraplegia and quadriplegia who's having uncontrolled bladder. So what is the best treatment for this uncontrolled bladder, especially if it is in young patients? Let's say
Neurogenic bladder, you mean?
neurogenic bladder, yes.
Neurogenic bladder. Neurogenic bladder can be of two types. One is upper motor neuron type of disease, another is lower motor neuron type. Uncontrolled is upper motor neuron type of disease. Patients having stroke or hemiplegia and or the thoracic or cervical fracture cases, then they can have uncontrolled bladder. So we manage these cases with few very good medicines are available nowadays. And if patient is still retaining urine, then we can do CIC. We can teach them this CIC, self-calibration, catheterization. So that is a very good option with the anticholinergics, and nowadays some beta-adrenergic medicines are available like Mirabackground in our country. I'm sure it is available in your country also. So
Yes.
we can add. We can do urodynamic study here. We have to do study here in our center that is called urodynamic study. By this, we can find out whether it is upper motor neuron type of disease or lower motor neuron type of disease. So urodynamic study or video urodynamics is very important.
Okay. How about this sacral nerve stimulation, doctor? Will it be beneficial for this kind of problems?
Yeah, nerve modulation techniques are there in one of our center. We are sending them for neuromodulation technique. By needle, we can stimulate these nerves and regular basis, then they start functioning. If it is not a complete transaction. So we have got a few experts working doing this. Neuromodulation therapy.
Okay, doctor. Thank you so much. Okay.
Any question from Oman? Bangladesh, any question? Any question from Iran? Iran and Iraq? We get large number of cases of stone disease, kidney stone cases here, and we have got all types of technique to remove these stones now with minimally invasive technique. And hardly we are doing, during my presentation, I must have told you, hardly we have done any open cases in last 2 decades, last 20 years. So all endoscopically managed. These are endourology. And we have got all basic instruments and advanced instruments to manage stone disease. We are removing all tumors, kidney tumors, laparoscopically nowadays. And where we need resection and reconstruction, then robot will assist. So robot assisted various techniques like cystectomy, then reconstruction of the neobladder. This can be done by robotic technique, robot assisted. Then we get large number of queries and patients from our neighboring countries for erectile dysfunction. That is very common in male population, erectile dysfunction, and due to social stigma in this, they don't come out with their complaint. But through this platform, through this our various centers, we can manage. In Africa, that erectile dysfunction management to start with. Almost 70 to 80% cases can be managed medically, and rest, if don't respond to medical management, then benign prosthesis can be put. 2 types of prosthesis, semi-rigid, 2-piece, and another is 3-piece prosthesis that is quite costly. AMS prosthesis is there, and we have got the facility for the implantation of this prosthesis. This inflatable 3-piece can give almost normal feeling. But another is semi-rigid. That is cheaper one, economical one with excellent result.
Can you hear me?
Yes, Mr. Bashir.
Doctor, a male patient with 27 years of age, having dribbling of urine last 4 years. So I did the USG is normal. I mean, bladder, prostate, everything is normal. So this is a reason for prostate cancer.
How much is PSA? Hello? Hello? Mr. Bashir, can you hear me? Mr. Bashir, can you hear me?
Hello, doctor.
Yeah. Yes, Dr. Bashir, please tell me. Please tell me. Dr. Shahir Bashir, please.
Yes, doctor. Yes, doctor.
Yeah.
PSA is 1.2 mg per m.
PSA is 1.2, then
1.2.
yeah, what next? 1.2 is within normal limits.
Yes. So, and the patient is now also complaining dribbling of urine.
We have to find out other causes of dribbling of urine. Whether he has undergone any surgery.
No, nothing. Just 27 years of age.
27 years of age.
Yes.
Then this may be a bladder neck obstruction, and we have to evaluate for this. You get the urine routine, urine culture, serum creatinine.
Yes. Culture, urine routine, everything I did. Everything is normal.
Ultrasound.
Ultrasound also, bladder and prostate is normal. And he told that when he is taking more sweet things, the dribbling of urine is more.
My dears, I think some kind of internet issues are in place with our doctor and Mr. Bashir. So maybe let's finish our webinar. And if you have any questions, you can find the feedback with us. You can write us. Also, please find my email in the chat, and please send your emails in terms to issue certificates of participation for today's webinar. And also, I want to announce the fact that we have planned our next webinar on December 28th, where the Georgian reproductologist Dr. Lily Guaramata will present some presentation regarding the infertility issues. So if any of you is interested in the following webinar, please write these facts to us as well. We also will share the link for and registration link for the following webinar, and also you can register there as well. So we will keep in touch. We are looking forward for your emails, looking forward to your participation in our following webinars, and thanks a lot for your time and your dedication. And I really want to thank our doctor, Dr. Zaman. You did the best presentation, and we really appreciate it. Thanks a lot for your participation, for your presentation, and hope to see you soon.
Thank you so much for all of you to spare time to hear this presentation. I am really grateful to all of you, and I wish we'll get more feedback on various issues, urology related issues, and I'll be very more than happy to answer all these queries. Thank you so much.
Okay, on the behalf
Thank
of
you,
the
madam.
Medhop.
Thank you for organizing this.
Okay. Thank you on the behalf of the Medhop. I always welcome you in our all of the next webinar. And for more, you can visit our website www.medhophealthsolutions.com. So see you all in next webinar. Thanks for your participation. We will shortly email you your certificates. Thanks again for all. Khuda Hafiz. Bye.
खुदा हाफिज बाय बाय
Salam.
खुदा हाफिज
Salam.
वालेकुम सलाम
Okay, on the behalf
Thank
of
you,
the
madam.
Medhop.
Thank you for organizing this.
Thank you on the behalf of the Medhop. I always welcome you in our all of the next webinar. And for more, you can visit our website www.medhophealthsolutions.com. So see you all in next webinar. Thanks for your participation. We will shortly email you your certificates. Thanks again for all. Khuda Hafiz. Bye.
खुदा हाफिज बाय बाय
Salam.
खुदा हाफिज
Salam.
वालेकुम सलाम